So this PowerPoint will go over medication administration, the non-parenteral medications, so everything besides the injections and IVs. So we're going to be talking about oral. Enteral is through a tube, an NG tube, gastric tube, sublingual, buccal, topical, ear, eye, nasal, and inhalation. Here are our learning outcomes specific to this PowerPoint. We will be discussing the rights of drug administration and the related professional responsibility for safe medication practice. That includes infection control and client teaching. We will apply guidelines and precautions for safe medication administration. And lastly, describe principles used to safely prepare and administer non-parenteral medications. The next PowerPoint will specifically discuss the parenteral medications.
So when you're getting ready to give a medication, you have to do a certain number of checks to make sure that you're giving the patient the right medication and the right dosage at the right time. We're going to talk about those rights in just a minute. So there are certain times that you need to look at this medication label. So the first one is when you reach for the container or the unit dose package. So most medications that are given in the hospital are packaged in unit dose packaging, which what that means is there's one pill for each little package, and there are different types of these unit dose packaging, and you'll see a variety of these when you go to clinical, but they'll all have the drug name, a dosage, and then they'll have a barcode on them so you can scan the barcode into the computer. So that the first time that you're going to check it is when you pull it out of the medication dispensing machine, wherever it might be. So you're going to look at your medication administration record. You're going to look and determine what medications are due at this particular time. You're going to go and you're going to look for those medications. And I like to go in order. I just start at the top and I work my way down, because if you have a patient that has multiple medications, you don't want to miss anything. And as I pull them out, I line them up on my medicine cart from right to left. You can do top to bottom. That maybe mimics the medication administration record in the computer, but some kind of system. You want to line them all up there because you want to make sure that you're not missing anything. So the first time you're going to check it is when you're going to pull the medication out of either out of the drawer, out of the dispensing machine. The second time is after you've retrieved that from the drawer, then you're going to hold it up next to the computer and you're going to compare to make sure, or next to the medication administration record. So CMAR is computerized medication administration record. And so you're going to compare that medication to what's ordered. So that's your second one. And then you're going to, I just put that down until I've checked all of mine. If you're only doing one or two, it won't be a very long time. But if you've got multiple medications, you're gonna check it, look for it in the drawer, make sure that's the correct medication. You're gonna hold it up against the MAR to check and make sure that that's the right medication. And then you're gonna take it to the patient's bedside. You're going to identify your patients. We're going to talk about that in a minute. And then you're going to check that medication again before you give it. So here are the rights of medication administration. So it used to be, I always say the 5 rights because there used to just be 5. Now there's 6, plus they've added 5 more. So there's a lot of rights, but they all make sense. So you want to give the right medication to the right patient in the right dosage, by the right route, at the right time, and for the right reason. And then this right reason is based on the right assessment, the right documentation, and the right response. And then some additional rights that we want to use to make sure our patients receive accurate and thorough information is they have a right to medication education, and then they have a right to refuse those medications. So every time you're giving a medication, you want to go through these rights in your head. Say, am I giving the right medication to the right patient in the right dosage at the right route at the right time and for the right reason? And before I talk about this slide, I want to just think back to on the last slide, the right assessment. So I want to make sure that you understand that it is so important to always assess your patient before you give any medications. So I've had students say to me, like their patient had insulin due at 7 a.m. So as soon as you get to the floor and you get out of report, I tell the patients to go in and do an assessment on their patient. So they go and they come back to me and they say, well, the patient's asleep. But if you're going to give a medication to a patient, you don't want to give them that medication until you have properly assessed that patient. Because if there's some kind of adverse event that happens after you give that medication, then you won't know what's different about that patient. So you always want to do the proper assessment before you give any kind of medication. All right, so let's move on to this slide. So identifying the patient. So you want to check the patient's identification bracelet. So I always have the patient, either hold out their arm or I get where I can see the bracelet and I ask them to state their name and give me their date of birth. So you want to check that. You don't want to enter the room and say, oh, hello, Mrs. Jones, how are you this morning? Can you tell me your name and date of birth? So, even a confused patient can say, well, I'm Mrs. Jones, because you just said that. So the first identifier is asking the patient to state his name, his or her name if possible, and also to tell, the second identifier is having them tell you their name or their date of birth. Usually most patients don't know their identification number or their medical record number, but you have the patient state their date of birth. If they're not able to do that, then you will compare the chart, whether it's in the computer or a paper chart. You compare the patient's name, you can compare identification numbers, medical record numbers, or birth dates that way, but the patient's not going to be able to state that to you. And then you want to compare it to the medication administration record. And so now that we have the scanner, most places you can scan the patient's their ID band, and that can be used as your third identifier. So when you're giving medications, there are some steps that are common with all types of medications. So as I go through each type of medication, I'm not going to repeat all of these things each time, but just I want to be clear that you do all of these things with every single patient, okay? So the first thing you're going to do is gather all the supplies that you need in order to give those medications. So in some places where the carts are in the room, you should have all your supplies in that room, in that cart. So as part of your initial assessment, when you go into the patient's room, you're going to not only assess the patient, but you're also going to assess the environment. So part of that assessing the environment is to make sure that you have everything that you need for the day. So if you go in and the cart is not stocked, they've used it up all of everything up during the night or the day before, then what you need to do is to make a list or make a mental list to make sure that you go and retrieve the supplies that you're going to need and stock that cart. So that is a nursing responsibility. A lot of times I hear students say, isn't that what the tech does? No, the nurse, it's your responsibility to make sure that you have everything that you're going to need to take care of that patient during that shift. And so you want to gather up your supplies, and this is especially important if the patient's in isolation, so that once you get gowned and gloves on, that you're not having to take all that off to go back out and get your supplies. So then the next thing, with every single patient, you're going to check your medication order to see what's ordered. If you have any questions about anything, if you don't know what the medications are and you need to look them up, then this is the time for you to do that. You want to check and make sure that the patient has, see if they have any allergies. They should have an allergy bracelet on. Even if they don't have allergies, then they should have a bracelet that says no known allergies or no known drug allergies on it. You need to know the medications, like I said, so this is your time to look over that order, see if there's anything that you don't know about, and go and look it up. If you need to, well, you'd have to perform hand hygiene before you go in the room anyway, and then if the patient needs any kind of personal protection equipment, or if you need to put on PPEs, if the patient's in some kind of contact or some kind of isolation precautions, then you have to put that your PPEs on before you go in the room. You want to identify the patient, just like we said, with the 3 identifiers. Have the patient state their name, state their date of birth, and then scan them to make sure that that is that you can compare it to the MAR and it's the correct patient. Then you're going to assess your patient, like I said, make sure that you do a head-to-toe assessment. You don't have to go into great detail, but you do want to do a quick basic head-to-toe assessment before you do any kind of medication administration. I've already said we're going to scan the barcode. Then you're going to put on gloves. And once you've given the medications, you're going to stay with the patient until it's administered. Never, ever, ever leave medication at the patient's bedside. If it's an oral medication, make sure that it is swallowed all the way down. If it hasn't swallowed all the way down, the patient might choke on it. And also, some patients might not take it if you just leave it at the bedside and go out and do something else. So I'm just going to tell you a little story. When I was a nursing student a long time ago, and I was working extra as a patient care tech in the evening, and I went into a patient's room, and I was back in a long time ago, the patients used to have a bedside table there that had some drawers. And so I was straightening things up in the patient's room, and I opened up the drawer, and there was a whole stockpile of medications in that drawer. And I was surprised by it, but I didn't say anything. I closed the drawer and I went out and I told the nurse. And the nurse came back in and she checked it and she talked to the patient. And as it turns out, the patient was thinking about committing suicide. So they had been saving up their medications. The nurses would just bring them in and leave them there and go on their merry way. They did not watch the patient take the medication. And so had I not found that and said something to the nurse, the patient might have carried out that suicide. So we were able to get the patient some help that the patient needed. So never ever leave that medication at the patient's bedside. If you're going to document that the patient took the medication, then you need to make sure that the patient took the medication. And then after you're done, you're going to document everything, and you're going to come back in the appropriate time frame and evaluate the patient's response to that medication. Especially if you give them pain medication, you want to go back and you'll have to document that their pain was relieved or partially relieved or not relieved at all. Okay, so for oral medications, they come in different forms, pills, tablets, capsules, but also liquid forms, elixir suspensions, and syrup. So I'm not going to go over detail about, well, I am going to go into some detail about pouring the liquid medication, but I just want you to see this picture here and see how the nurse is at eye level with that medication. That is the way you should be when you're pouring liquid medication, because if you just look from the top, you can't make sure that you have the medicine poured in the correct amount. So you've got to get down at eye level to make sure that it's at the right marking on the cup. So some special considerations with oral medications. So sometimes the order will be for half of a tablet. So unless it's scored, you can't break a tablet. So providers know which tablets are scored and which ones are not, and so they'll order, they should only order half a tablet if it's a scored medication. Now, some places will provide a slicer for you. If it's scored, it should break fairly easily, but don't try to cut a medication that's not scored. Enteric-coated tablets have a coating that prevents it from being absorbed in the stomach, where it might irritate the stomach mucosa. So, for example, aspirin is a medication like that. So, aspirin comes in an enteric coating. You never want to cut or crush a medication that is enteric-coated. And there is a list on the Institute of Safe Medication Practices website. There's a list of medications that have an enteric coating that shouldn't be split or crushed. And you don't want patients to chew or crush not just medicines that have an enteric coating, but medicines that are extended release or controlled release or sustained action or long acting, because those also have a special coating that dissolves just in the right increments of time for that medication to be given and absorbed by the patient over that extended period of time. So if you crush it or you have them chew it or you break it, then it's not going to have that same effect. So oral medications can be given enteral also, which means being given through a tube, an NG tube or a Dobhoff tube. They can be given sublingually, which means you put it under the tongue, or it can be given buccally, which means you put the drug between the tongue and the cheek. So your mouth is a very vascular area, so giving medication sublingually or buccally is a pretty good way to give medications as long as as long as it's supposed to be given that way. There are also some medications, like I used to take medication for my migraine, that just you put it on your tongue and it just dissolves into the tongue and it works right away. So they're very good. It's a very good route for medication administration, as long as the medication is meant to be given that way. So some medications can be given topically in different forms. We're going to talk about each one of these. So topical administration of medications can be given in skin applications. Topical, that's generally what people think of as topical. So just some general rules with the topical. So you want to make sure that you always wear gloves so that the medication isn't absorbed into your hands. Before you put the medication on, you want to take off any old patches of the same medication, and you're going to fold them in half with the adhesive sides sticking together, and you're going to dispose of them properly. Make sure you've got your gloves on when you're doing that so that you don't get any medication on your skin. And then you could actually change your gloves if you feel like some of the medication got on there. You don't have to, but you can. And then where the new patch is going to go, you're going to cleanse the skin to make sure that it doesn't have any lotion or oil there. You want to make sure that there's also no breaks in the skin, no rashes or anything like that when you're putting a medicine patch. You want to rotate your application sites, because if you keep putting the medication back in the same site, it may make it less effective. And then you want to make sure that you put the date and time on a piece of paper and put that on the patch or put it near the patch. Sometimes nurses will write on the patch the date and time, but that ballpoint pen could go through, so it's preferable that you avoid that you make a little, use a piece of tape and put the date and time on that. So that way they'll know if the next nurse comes in, they'll know that that's the patch that you put on, so they'll have to take that one off. So when you get ready to give the medication, that medication is, and you can see the picture here, there's a variety of medications that come in as like Nicoderm is medication for patients to help them stop smoking while they're in the hospital. Nitrodur is a form of nitroglycerin that can be given through the patch, and the patches are really good because they're kind of sustained release, so it gives the medication over a period of time. There are narcotics that come in the patch form, so there's a lot of really important medications that are given topically, and it works very well. So you want to remove the patch from its protective package or covering, and remove the covering on the patch without touching the medication. So it'll be in a little package that's all sealed up. So you open that up, take it out, and then there'll also be a little, like a plastic piece over the medication. So you want to carefully peel that off without touching it, and you want to place it in an area where there's no breaks in the skin. You also want to read the manufacturer's instructions about putting it where there's a lot of hair, because sometimes they don't recommend that, or they recommend shaving the area so that the medication adheres to the skin and not to the hair. And then you want to use the palm of your hand to firmly press about 10 seconds to make sure that it's in place. But don't rub it in because that can cause a difference in the way it's absorbed. So with eye installations or irrigations, they come in different forms: eye drops, ointments, irrigation, and medication discs. We're not going to really talk about irrigation too much. You would irrigate your eyes if you got splashed with something that could be damaging to your eyes. Some units will have an eye wash station where it has little spouts that come up, and you can flush your eyes out with water, with just regular water, and that would be one of the reasons why you would irrigate an eye. Or if there's something caught in the eye that you can't get out, you could irrigate it as well. And then medication discs are very similar to contact lenses, and they're not very commonly used, so we're not going to go over those. You'd have to read the package insert if you did. I do want to point out on this diagram where the inner canthus and the outer canthus is. That just means the corners of the eye, the inner corner and the outer corner. And then the lacrimal ducts are, if you notice, they're in the inner aspect of the eye. And if you look at your own eye, you have a little, it looks like a little hole there right on your lower eyelid, and that is your lacrimal duct. And so when you give medications, when you give eye drops and ointments, you want to, after you give it, we'll talk about this in a minute, you're just going to gently press on that, and that keeps the medication from entering into the systemic circulation, because some medications that you give through eye drops can give a systemic reaction if it gets into that lacrimal duct. So with eye drops, you're going to give the patient a tissue, because sometimes the medication may spill over out of the eye. You're going to cleanse the eye and the eyelashes with saline moistened gauze if it needs to be done. When you clean it, you only use one area of the gauze per swipe. So you can swipe with one side, then turn it over and swipe the other eye with the other side, or a different part of the eye. So you want to have the patient either sitting up and with their head tilted back, or they can lay on the bed with their head over a pillow. If the patient has a cervical spinal injury, you don't want to hyperextend that neck, so you just be very careful with those patients. You can take the cap off the bottle, but don't touch the inside because that's sterile. So all of these are like medical asepsis, but you don't want to touch that cap to anything, or the tip of the bottle to anything. All right. And then you're going to have the patient focus on a spot on the ceiling, and then you're going to put a thumb or two fingers near the margin of the lower eyelid and pull it down, and that should be bony prominence, sorry, not boy prominence. And then you're going to hold the dropper close to the eye, but don't touch it, and squeeze the container to dispense the number of drops that are supposed to be given. So you're going to put the drops on the lower conjunctival sac, but you don't want the medication to fall onto the cornea. And then you're going to release that lower lid and have the patient gently close their eyes. And you're going to apply pressure over that inner canthus to prevent the drops from flowing into that tear duct. And tell the patient to not rub the eye as much as they want to. They need to not do that. If you're giving ointments, you're going to follow pretty much the same procedure, except instead of putting the number of drops, you're going to distribute a small amount of that ointment across the lower conjunctival sac from the inner to the outer canthus. And then afterwards, the patient should close their eyes and move the eye from side to side and up and down to spread that ointment under the lid and over the surface of the eye. And they're going to be blurry. They're going to have blurry vision temporarily, but tell them not to rub their eye. So we're going to talk about ear installation and irrigation. So again, just some terminology. So that whole outer part of the ear, including the helix and Darwin's tubercle and the lobule at the bottom, all of that is considered the pinna. And then the little cartilage at the front of your ear, you can feel that right at the very front next to your face. That's called the tragus. So you're going to need to know where those places are. So when you give ear drops, there's a certain way that you have to pull on the ear in order to straighten out the ear canal and get the medication to go in the right way. So I put this little pictorial thing here because it kind of helps you to remember. So on an adult, you're going to pull the pinna up and back. On a child that's less than 3 years old, you're going to pull the pinna straight down. And then a school-age child, you're going to pull the pinna straight back. So there's a picture on the next page of each of those. So here's the picture. So the top left is an adult pulling up. Then the picture B is a child, so they pull it straight back. And then picture C is a young child, so you pull it straight down. So again, just like with the eye drops, you're going to clean any drainage off the external ear with a saline moistened cotton ball or gauze pad. You have the patient lie on the unaffected side. So if you're going to put drops in the right ear, you're going to have them lay on the left ear. And then or have them sit with the head tilted to the side so that the affected ear is uppermost. And then you're going to, if it draws up into a dropper, you're going to draw it up. If not, if it's just a bottle that is also the dropper, then you're going to pull the pinna out of, straighten the auditory canal by pulling the pinna up and back for an adult, straight back for a child, or down for a child under 3. And then again, you want to keep the medication dispenser and drops sterile. So you're going to hold the dropper in the ear, but with the tip not touching anything. And then you're going to allow the drops to fall on the side of the ear, not on the middle of the canal. And that should say to avoid getting the medication directly onto the tympanic membrane. So then after you let go of the ear, you're going to have the patient still keep their head in that position, but you're going to gently press on that tragus a couple times, and that will help move the medication from the ear canal down toward the tympanic membrane. And then if the doctor orders it, you may have to put a cotton ball just kind of loosely in the ear canal to keep the medication from leaking back out. And you're going to wait 5 minutes before you give drops in the other ear if they're ordered to be in the other ear. And the irrigation they might use for like if some foreign body's in the ear or if there's too much wax. So they usually use normal saline, but it could be antiseptic. And you want to make sure that it's warm to room temperature. And same thing with ear drops. You want to make sure that those are at room temperature because you can give the patient a terrible headache if they're too hot or too cold. So to give something in the nose, this is used for allergies, sinus infections, congestion, or even some kind of systemic medications. And you want to use medical aseptic technique. So you have the patient blow their nose before you give the medication. They should be sitting up with the head tilted back, and they have to be able to maintain this position for a few minutes after you put the medication in. So you're going to hold up the tip of the nose, place the dropper just inside the nares and without touching the nares, and instill the prescribed amount into one and then into the other. Now, if it's a spray, you're going to have them blow their nose again, have them tilt their head back, have the patient inhale gently through the nose as the spray is being administered. But some of them they shouldn't inhale, so you have to make sure that you read the medication labels. And you're going to have them put their finger over the other nostril just to make sure that the medication, when you spray it, the medication doesn't come out the other side. You want to gently kind of roll the bottle between your hands to make sure none of the medication is settled, and then insert the tip of the nose into the bottle, tip of the nose piece of the bottle into one of the nostrils. And you're going to compress the bottle to release one spray at a time as the patient breathes in. You're going to keep the medication container compressed, and then you remove it from the nostril, because if you don't, then it creates a vacuum, could suck some stuff back into the bottle, and you don't want to do that. And then after you've removed it from the nose, you're going to release the compressed state. And then you want the patient to hold their breath for a few seconds and then breathe out slowly through the mouth. And then you repeat the other side if it's indicated. And then you want to wipe clean carefully the outside of the nose of that bottle with a dry tissue or cloth. And tell the patient to avoid blowing their nose for about 5 to 10 minutes, because you don't want them to blow out that medication you just put in there. So with vaginal applications, this could be either creams or suppositories. So for women, the normal mucous membranes in the vagina are the best protection against pathogens. So you want to ask the patient to void first before you insert the medication. And the patient's going to lie on their back with their knees flexed, kind of like a modified lithotomy position. You want to make sure that you maintain their privacy by closing the curtains and putting drapes over the patient so that they're not as exposed as any more than they have to be. You want to make sure that there's adequate lighting so you can see. So you're going to spread you definitely would have on gloves. For all of these, you're going to have on gloves. So you're going to spread the labia with your fingers, clean the area at the vaginal orifice with a washcloth and warm water, and then definitely wipe front to back. And then you're going to put on new gloves and fill the applicator with the amount of cream or suppository. And then lubricate the tip. Most places have like clear KY jelly or Surgi lube that you use for the lubrication. The suppository, the end that's rounded is what goes into the patient first, and that can be lubricated with a water-soluble lubricant. For cream, you spread the labia and introduce the applicator. So these pictures up here at the top, the one on the left is a suppository, the one on the right is a cream and with an applicator. And so once you put this medication in, you want to have the patient remain in the supine position. Then they can put their legs down, but just laying on their back for 5 to 10 minutes so that the medication stays in there and doesn't come back out. And then you might want to offer them like a perineal pad to collect any drainage. As for the suppository, with all suppositories, whether they're vaginal or rectal, you want to keep them stored in the refrigerator so they don't melt in your hand or soften and not be effective or not be able to instill them the way you should. You want to put lubrication on your finger, on the gloved finger, on your dominant hand. Then you're going to spread the labia, insert the rounded end of the suppository along the posterior wall of the vaginal canal to the length of your finger. And you ask the patient again to lay on their back for 5 to 10 minutes. So rectal installations are very similar. These can be, usually it's a suppository, can be used for local effects like a laxative or a stool softener, or more systemic, like you can give Tylenol, which is acetaminophen, and antiemetics, the anti-nausea medication, which is perfect. If somebody's nauseated and they can't swallow, then you can give them a suppository. So you do want to make sure that before you give a suppository that you look at the patient's white blood cell count and platelet counts. If either are too low, the white blood cell count, you might introduce some pathogens into them, and that could make the patient's condition worse if their white count is low, or if their platelet count is low, then they might bleed. So you want to make sure that you do not give rectal suppositories to either of those classification of patients. Patients that have cardiac arrhythmias, putting your finger in the rectum can cause some worsening of those arrhythmias, so they should not receive rectal suppositories. And you always want to wear clean gloves. So you want the patient to lay on their left side in the Sims position, and they lay on the left side because that's the way the rectum goes. It goes to the left. You're going to drape them again to only expose the buttocks. You're going to remove the suppository with your gloves on. You're going to put some lubricant on the rounded end and insert it, lubricate the index finger of your dominant hand and insert it. So you're going to separate the buttocks with your non-dominant hand. Tell the patient to take slow, deep breaths. And then you use your index finger and insert that suppository along the rectal wall, about 3 to 4 inches. And then you're going to clean off any stool or lubricant from around the anus. Now, if you put your finger in there, there's stool in there, you don't want to put the medication in because then it's not going to be absorbed, especially if it's like a acetaminophen or anti-nausea medicine. If it's a stool softener, then that's fine. But if it's something that needs to be absorbed systemically, then that's going to make it more difficult, and you shouldn't put that in until the patient has gone to the bathroom. Afterwards, you're going to release the buttocks, tell the patient to remain on their side for 5 minutes, and try to retain the suppository as long as possible so that it has time to absorb the medication. So inhaled medications are either aerosolized, can be delivered in small particles, or breathed in by the patient. So most commonly you think about asthma medications for this. It can be a little difficult to get the correct dose, but if you follow these guidelines, it can be very effective. And they can also be delivered by an atomizer or a nebulizer. So the first type are metered dose inhalers, or MDIs. So you're going to take the mouthpiece off and shake the inhaler so that the medication hasn't settled. And if you're using a spacer like in that previous picture, then you're going to remove the cover and attach the MDI spacer to it. And the spacers are really good because sometimes patients can't breathe in when the medication is being delivered, and so that helps to get a better better delivery of the medication. So you have the patient put their mouth around the spacer's mouthpiece, grasping it securely with their teeth and lips. And if they're not using a spacer, you have the patient take a deep breath and exhale, put the inhaler 1 to 2 inches from the mouth, and inhale slowly and deeply while depressing the medication. So only the spacer do you put in your mouth. The inhalers, if you're using it without a spacer, you hold it close to the mouth but not in the mouth. They would breathe normally through the spacer. And we don't have any of these to show you, but hopefully when you go to the hospital, I know at Gwinnett Medical Center, the respiratory therapists give these medications, so make sure that when you're there, you want to observe them giving the medication. The patient has to hold their breath for 5 to 10 seconds, or as long as they possibly can, before they exhale, and you have to wait 1 to 5 minutes before you give a second puff. And then afterwards, the patient should gargle and rinse with tap water after using the MDI, especially if it has any kind of steroid in it, because to keep that from causing any damage to the mucosa in the mouth. And then you want to kind of clean off that multi-dose inhaler. So dry powdered inhalers, there's some pictures here of some different types. The patient with these, they have to be able to take a deep breath. So it's similar to the MDI inhalers. You're going to take the mouthpiece off. You're going to activate the inhaler, have the patient breathe out slowly and completely without breathing into this inhaler. And then they should put their teeth over it and seal their lips around it, but not block the opening with the tongue or the teeth, and have them breathe in quickly and deeply for longer than 2 to 3 seconds. And then you're going to load the dose, activate the inhaler. Well, you would do all this before you put it in the patient's mouth. Have the patient breathe out slowly, place it over the teeth, and then, oh, I'm sorry, it's the same stuff as on the last slide. Okay, we're going to skip this then. Okay, and then when you're done, you're going to remove the inhaler from the mouth, tell the patient to hold his or her breath for 5 to 10 seconds, or as long as they possibly can, and then you need to wait 1 to 5 minutes for the next puff. after you've given the right amount, you put the cap back on it and have the patient gargle or rinse their mouth with tap water. Now, you can also use a nebulizer to deliver medications. So you're going to go through all the steps that we just described. You're going to remove the nebulizer cup from the device. So you can see that's that kind of blue rounded piece there. You put your medication in there, you screw it back on. And then this is what a nebulizer machine looks like. The patient's going to, you turn it on, it has compressed air, sometimes it has oxygen. Once you turn it on, you want to make sure there's like a fine mist of the medication. And then they put the mouthpiece into their mouth and kind of make a seal with their teeth and lips and inhale slowly and deeply through the mouth and hold each breath for a slight pause before they exhale. So here's what it kind of looks like. Sometimes people will call this like a peace pipe. As they're doing it, the steam comes out the other end, so that's what makes it look like a peace pipe. So you have the patient, they need to inhale all this medication until it's completely used up, and that usually takes about 15 minutes, and then you want to have them gargle a rinse with water. And for children, I mean, these are used for asthma patients. They come in cute little animal shapes, so the patients will enjoy having it done and not hate it quite so much.